Afternoon. Welcome to Life as a Clinician-Scientist, Rural and Regional. I'm David Mackey. I would like to, before we start, acknowledge the traditional custodians of the many lands on which we meet today and pay my respect to their elders past and present. We extend that respect to the Aboriginal and Torres Strait Islander people who are joining us today online. Aboriginal and Torres Strait Islander peoples were the first scientists in the nation, and they remain the spiritual and cultural custodians of their land. I'm David Mackey. I'm an ophthalmologist at the University of Western Australia. I originally graduated at the University of Tasmania before training in ophthalmology in Melbourne and fellowships in the United States and United Kingdom. And returning to Australia, I've been involved in research projects such as the Glaucoma Inheritance Study in Tasmania, the Norfolk Island Eye Study, the Brisbane Adolescent Twin Study, and the Busselton Healthy Ageing Study, covering much of the regional areas of Australia. We're delighted to have you join us today for many, perhaps your first step towards embarking on a career combining clinical practice with research. Perhaps some of you are already on this journey and looking for advice on how to stay on course. And perhaps some of you aren't quite sure yet exactly what you want to do. But the fact that you've joined us here says that you're committed and intrigued and thinking about how your clinical life might one day merge with research in regional or rural parts of the country. The Academy of Health and Medical Sciences has been running the Life as a Clinician-Scientist event for 9 years now, under the umbrella of our mentorship program. The mentorship program is overseen by one of our fellows, Professor Louise Maple-Brown, who is based at the Menzies School of Health Research in Darwin. Louise has been instrumental in championing this event today, our very first for rural and regional audiences, and it's my pleasure to represent her and the Academy's Mentorship Committee here today. We have some wonderful speakers joining us from across the country who will speak to you about their own career journeys and how they came to find success as clinician researchers, and particularly how success looks different for everyone, and even more so on the backdrop of working outside the urban setting. You'll note the options to ask questions of our speakers, and we encourage you to do so at any time throughout the presentations, and we'll allow time for as many of them to be answered as possible. You'll need to exit the full screen mode to see the Q&A answers on the side. I'd like to acknowledge the generosity of our platinum sponsors, the Centenary Institute, the Hunter Medical Research Institute, the Murdoch Children's Research Institute, the University of Melbourne, the University of New South Wales, the University of Sydney, and the University of Newcastle. We're also grateful for the other institutions whose logos are shown here from around the country who also support the program. Now, a little bit about the Academy. The Academy is one of 5 learned academies in Australia, and we are the impartial and authoritative voice of health and medical research, medical sciences in Australia. We have 502 fellows, the best and brightest minds in the field of medicine and health sciences, elected by peers for outstanding achievements and exceptional contributions to the sector. We are uniquely positioned to convene cross-sector stakeholders from across Australia to address pressing health challenges, and our purpose to advance research and innovation in Australia to improve everyone's health. We do this by celebrating and strengthening research, influencing policy, supporting Aboriginal and Torres Strait Islander health and well-being, building the interface between health, academia and industry, and as you will discover today, nurturing future research leaders like yourselves. We do this through our mentorship program, initiatives and events like this. The Life as a Clinician-Scientist program is now in its 9th year, and we have had more than 200 speakers sharing their wisdom over 32 events. We value your feedback so we can continue to grow this event series. Please help us by completing the survey at the end of the session. We are recording presentations today, and these, as well as over 150 other inspirational videos, will be available on the Academy YouTube channel in coming weeks. It now gives me great pleasure to introduce our first keynote speaker, Professor Jonathan Golledge. Professor Jonathan Golledge holds the conjoint positions of Distinguished Professor at James Cook University and Preeminent Staff Specialist in Vascular Surgery at Townsville University Hospital. He trained as a vascular surgeon in the UK, including undergraduate and postgraduate qualifications from Cambridge University. In 2000, he moved to Australia and completed fellowships in Adelaide before his appointment as a consultant in Townsville. Over the past 20 years, he has directed a combined preclinical and clinical research program focused on improving outcomes for lower limb peripheral artery disease, abdominal aortic aneurysm, diabetic-related foot disease, and carotid artery disease. Please welcome Professor Golledge.
Well, thanks very much, David, for that explanation and for the introduction. And thanks to the Academy and to Louise, yourself, and Layla for organising this meeting. So this is an area that's very close to my heart, the clinician researcher role and regional remote. So it's a great honour to talk on this area. So there are lots of reasons we're advised to get involved in research, particularly in relation to career advancement. But I think the key one for me has been the insight it has provided in patient management and developing my own ability to develop models of care for patients that I think are going to be suited to my local patients. So for much of the talk, I'm going to discuss the relevance of that to one of the areas that we've been investigating, that of peripheral artery disease. Now, I started out here in snowy Wales, a place called Swansea, where I was until I was about 13 years old. My father had to move. He was a warehouse superintendent because his job changed. So we ended up in this sleepy village called Thornbury, which is near Bristol. There wasn't a lot to do in Thornbury, so I had to work pretty hard at exams because there really wasn't a lot else to do. So I was very lucky to get into Cambridge University, as you hear. This is the Bridge of Sighs, St John's College. And after I qualified, I ended up in London, Imperial College, or as it was then, Charing Cross Hospital. So I started doing some research then and was lucky to work with Janet Powell, a very eminent researcher in the area of abdominal aortic aneurysm. So I decided to spend a year in Adelaide at the end of my training. This is Repatriation Hospital here in Adelaide. And I was living on the beach and working 10 minutes. So sort of going back to the UK didn't seem such an amazing idea. So I seemed to lose my return ticket. And a job came up here in Townsville. You can see the brand spanking new hospital there and the university. Now, when I first arrived in Townsville for my consultant job, the laboratories looked a bit more like this, so it wasn't that developed. And I was struggling with the job of being 1 and 2 on call, trying to set up research practice. But I was pretty lucky because I met some really exciting and very capable junior investigators. And these are some of the many amazing people I've had the opportunity to work with. Rochelle, there, my first honours student, is now a neurosurgeon in Brisbane. And we can go on and talk about all these people. But I'd like to get to the sort of nitty-gritty of what I've been doing. So 3 programs we were running, abdominal leukemias, and probably the area I'm most known for, but peripheral artery disease is what I'm going to talk about today. So peripheral artery disease, blocked leg arteries. I'm sure you know what this is, and there's many risk factors well known. One of the ones that hasn't had a lot of press, anxiety and depression, which is relevant to the story I'm going to tell you today. So peripheral artery disease, very relevant to regional and remote Australia. Firstly, this is a systematic review carried out back in 2021, which said Australia had a minor and major amputation rate of the lower limb much higher than a number of other high-income countries you can see listed here. So very relevant to Australia as a starting point. And if we look at a map of Australia, the very blue areas here are where the major amputation rates are much higher than the population would be for the population that they would be expected to be. So what this basically means is that regional and remote areas have very high burden of major amputation compared to capital cities. And we looked at this in our region of North Queensland, and indeed the major amputation rates are consistently higher in North Queensland than the national average, particularly in Aboriginal and Torres Strait Islander persons. But the burden of peripheral artery disease is not limited to that. These patients also have a very high rate of major adverse cardiovascular events. So heart attack, stroke, cardiovascular death, and requirement for surgical procedures. This varies dependent on what they present with, but the rates are very high. For example, a patient comes with a ischemic foot ulcer can expect to have a 13% risk of heart attack in the next 2 years, based on our data here from regional Queensland. But that's not the end of it there. These patients also have marked impairment of physical activity and quality of life. So this is a study we carried out a few years ago comparing accelerometer 7-day step counts, 6-minute walk distance, and scores for a health-related quality of life instrument in patients with peripheral artery disease and healthy controls. And you can see all these measures are markedly reduced. So what can we do to help patients with these sort of physical limitations due to peripheral artery disease? Well, there's really been 3 main treatments that have been looked at in randomized controlled trials: a drug called cilostazol, various revascularization operations, so particularly stents and balloons, these type of procedures, or a variety of exercise programs, either those carried out at a center, so-called supervised exercise programs where an exercise physiologist supervised the sessions, or home exercise programs, which might be a structured program that the patient is told to go away and do on their own. And what we did in this meta-analysis was look at the effect of these from randomized controlled trials on walking distances. And you can see, despite the popularity of surgical procedures, both with patients and clinicians, there's not very good evidence that these actually improve walking distance for this problem. And most of the evidence is from exercise programs, particularly supervised exercise programs, but to a lesser degree for home exercise programs. So the question really is, how do we help patients, particularly those in regional and remote areas, to carry out an exercise program? So we were interested in this study carried out by Mackey and colleagues in Scotland. Mackey visited us for a while. She's a psychologist, and she carried out a randomized controlled trial, 58 patients, randomized to 4 psychological sessions, so behavior interventional sessions, based on trying to persuade patients to carry out a home exercise program, deal with the challenges that might bring, because the patients will get leg pain when they walk. And amazingly, Mackey found out that 4 sessions with her could lead to 1,000 more steps walked on accelerometer in the intervention group for up to 2 years. So this was, quite an incredible change. And also, their requirement for surgery was halved in the patients having this sort of intervention. So I met Maggie, a very sort of persuasive Scottish lady, shall we say, and I wasn't sure how generalizable that was. So we decided to carry out our own randomized controlled trial. So we took patients with walking impairment due to peripheral artery disease, and we randomized them between 4 behavior sessions, so very similar to what Maggie had organized. These were counseling sessions, but they were delivered by allied health professionals, understanding that we might not have enough psychologists to deliver these sessions. They were trained by a psychologist, the eminent Nicola Burton, and we had a control group. These patients just received friendly phone calls, empathetic responses, not really based on physical activity. And we assessed outcomes over the first 2 years in terms of walking, based on accelerometer walking in particular, and also quality of life. And we extended follow-up for up to 6 years to look at cardiovascular events. So I mentioned these patients, high risk of cardiovascular events. And this was the main outcome for the study, the intervention group shown in red, the control group in blue. So you can see that the steps walked per day did sort of have a small spike at 4 months, but this wasn't actually a significant difference. So really very little benefit of our 4 sessions on the amount of physical activity undertaken, which was very disappointing. But we did see improvement in quality of life. So this is one of the quality of life instruments, so-called PADQUAL. It looks at physical aspects of quality of life in patients with peripheral artery disease. You can see the intervention group here shown in purple, significant improvement in their quality of life at 4, 12, 24 months. So that's pretty good news. And most remarkably, what we saw in the extended follow-up is in the intervention group, the incidence of major adverse cardiovascular events, heart attack, stroke, cardiovascular death, markedly reduced in the intervention group compared to control. In fact, hazard ratio showed a halving in the intervention rate. So what does that all mean? Well, we carried out some further analysis, adjusting for some of the changes we had seen, so adjusting for changes in quality of life. And we also saw that anxiety and depression were scores for these were reduced in the intervention group. And these secondary analysis suggested that these were driving the benefit in terms of reduction of cardiovascular events. Now, anxiety and depression are very common in patients with peripheral artery disease. This was a study carried out by our colleagues in Adelaide and also internationally in the US, showing that around 11% of patients with peripheral artery disease have depression, and that scores for anxiety and depression are very predictive of what quality of life is in these patient group. And indeed, there's also data that patients who have both peripheral artery disease and depression are at higher risk of cardiovascular events and also limb events. So this was our theory of what we were seeing in the randomized controlled trial that I mentioned. So our counseling intervention, while not directly improving physical activity, provided patients a way to start to take control of their problem. They knew what they could do to benefit themselves better. They were helped to overcome some of the challenges, and perhaps this was instrumental in leading to less depression, anxiety, and some level of control. We know that depression and anxiety lead to systemic inflammation, which is a risk factor for cardiovascular events. So really an area where we need to understand more about this relationship and provide some new models of care for our patient group. Now, I mentioned that our program was not effective in improving either physical activity or walking distance. So there was more work to do on that. So we actually carried out a survey with the patients involved in the trial, and they said they really needed a bit more help than just 4 counseling sessions. They really needed help from supervision at home, and indeed there is data that supervision of home exercise programs is more likely to improve walking distance. So we've now designed teleartery. This includes both the counselling intervention that I've mentioned, but also a telehealth exercise program delivered by accredited exercise physiologists. And it's been designed to be able to carry it out at home. So this is suitable for regional and remote patients who can't come to a centre. And we're hoping this combined program will be beneficial in both improving physical activity, but also in improving quality of life and reducing cardiovascular risk. So we're currently testing this in 2 trials, one trial versus usual care, and also a trial comparing with center-based exercise, thanks to support from MRFF. So what have I learned from research in combination with clinical practice? Well, it definitely allows you to develop your own ideas about how you manage a particular disease problem and improves your individual care of clinical patients, in my opinion. It allows you to identify your own profile and areas where you've got extra interest, and allows you to collaborate and develop new insight with a range of really capable people, both locally, nationally, and internationally. And so I've no doubt it's improved my care of patients. Of course, there are a few downsides to research. It's very time consuming. There is a lot of approval process that you need, and it's very competitive. A lot of people are interested in research. So everything to do with research, be it publishing or getting funding, is very competitive. So persistence and robustness is a must. In terms of running a program, I think you need to have a bit of confidence and vision when you're setting up. It helps to have things that can tick along in the background, things like registries you set up so you can get patients enrolled. Biobanks can be useful. Understand what your competitive edge is. There's no point in investigating a problem that you're rarely going to see in your region. So you need to sort of adapt to your local environment to a degree. Collaboration is obviously good, but best if it comes from a position of strength. Get it set up first, and then you can really start to collaborate effectively. So I'd like to finish by thanking all the people who do the work, who are part of our group, and all the collaborators and research funders, and most of all, patients and colleagues. Thank you for your attention.
Thank you very much, Jonathan. That was a really fascinating presentation in the interest of how much work you're able to achieve in a regional centre. One question I have, while we're waiting for some of the audience to send questions through, do you think that getting grants and funding to do research in regional areas is harder than if you're in Melbourne or Sydney?
I think it depends very much on the program and how you approach it. It's like everything. I remember when I first started, NHMRC project grants were around, and the success rate wasn't too bad. And I think, I had some luck with that. And then we had a period where it was really, really hard to get any money. NHMRC has become sort of, super competitive, perhaps too competitive. But MRFF came along, and I think that's been sort of helpful to us in regional remote areas where, we've probably got some unique challenges which are appealing to the MRFF in a way, because it's something a little different than perhaps that, it's a fancy science sort of approach. It's more what's going to work with the patients. So it swings and roundabouts, but I think wherever you are, you just got to be very happy to go, well, this is my 5th attempt, but I'm going to revise it again. And it's not a minor revision, you've got to have that level of robustness. I mean, not long ago, a group of us got an NHMR Synergy grant. That was the 5th go. And it was like completely rewritten every time, for 4 or 5 months work. So it comes down to a lot of that, I'm afraid.
A lot of perseverance. Do we have any questions from the audience? or perhaps the other panel members. One question I might ask, this is actually a question Leela sent through. I'm considering research in rural Australia because I think it will be good for my career. And reading the rest of that. No, I can't see the rest of the question, Leila. I've got it now. Correct. But feel unsure about the challenges affected in career progression. So I remember being told this earlier when I chose to do my intern year in Launceston. Oh, this might interfere with getting back into the training programs in the city. Jonathan, what's your feeling about that?
Well, obviously I'm a bit biased because I'm in a regional centre. I mean, we've had some really amazing people who've done research with us, who've got into, specialist programs. So, it sort of depends when you're going to do it in your career. I think definitely, obviously, I would encourage you to get involved in research. It helps to have, someone to help you, mentor you, but you do need a few things to do research, I think. You probably need, persistence and hard work, and the time, number one. And you also need to probably be quite good at critical thinking, ultimately. You need to have an ability yourself to work things out. So I think if you've got those two things, then you're going to be very successful in research. That doesn't mean, what is the art of success? It doesn't mean you're going to get every grant you apply for, obviously not. So I'd encourage you to do it. It's just about thinking about it beforehand and planning where you do it best.
Okay, so one of the questions has come through. What was your motivation for engaging in research?
Yeah, that's a good question. Simply, I was in the UK when I was a junior doctor, and it was the publish or perish era. So you need to get involved in research to career progress. So I remember as a medical student getting involved in some research. And I think that's probably happens for a lot of clinicians. And some people like it and some people don't. So I liked it after I got involved in it. But the motivation was probably driven by that initially, but then a new motivation arises. And I think that's what happens with most people who get into research.
Thank you. And another question. I've just commenced my PhD part-time. How do you balance, the patient care with doing the research?
Yeah, that's a tricky question to always answer, because I think it varies from person to person. You've got to want to work hard, I think, number one. But a lot of people do, and that's good. I would say the value of research, which I didn't talk a lot about, is it allows you to continue to use your brain a lot. And I think if you're that sort of person who thinks academically, wants to do that, I would definitely advise you to get involved in research, because just being bombarded all the time with clinical practice, I see some of my colleagues, they sort of get a bit worn out with that. I think it really helps you avoid burnout and feel that you've got something that you're really interested and involved in. Not that you're not interested in clinical care either, but if I did that 100%, I think I would be more worn out by it. Similarly, just doing research 100%, I'd probably be worn out by it as well. So I think having the balance I've really enjoyed, but it's hard to control the two.
Right. Well, thank you very much for your insights with that, Jonathan. It was a great presentation. I'd like to now move on to our next speaker. So Professor Anna Ralph, and I'll check I'm sharing my slide correctly. So Our next speaker, Anna Ralph, is a senior specialist in infectious diseases and general medicine at Royal Darwin and Palmerston Hospitals. She is also Deputy Director Research at the Menzies School of Health, where she leads a number of research programs. She co-edits the Australian Rheumatic Fever and Rheumatic Heart Disease Guidelines and serves on the editorial board of the Medical Journal of Australia. Please welcome Professor Ralph.
Thank you so much for that welcome, and thanks so much to the Academy for inviting me to speak. So I'm just going to see if the sharing is going to work. Are we in the right mode there? If you can give me a nod, David, if that's all good. Thank you so much. So I'm joining you from the unceded lands of the Larrakia people here in Darwin, and I acknowledge the abiding cultural custodianship of this land that they provide, and I pay my deep respects to Larrakia elders, and also acknowledge First Nations people who are joining us in the meeting today. So look, I'm going to take the perspective of a medical clinician researcher, much the same as Jonathan has done. And the questions that came out of the discussion there is going to be a lot of overlap in these talks, which isn't too unexpected given that we were both asked to speak about fairly similar things. So I know that there's many in the audience who are from nursing, allied health and other diverse backgrounds. So hopefully there's something that you can take away from this talk, something of relevance for everyone. So what does it involve to be a clinician researcher? I think this is relevant to address because I do get asked this often by registrars. So how did you get into, doing what you do? I sort of think of it as being sort of two models, I guess, of potentially sort of how you end up working in this space. And so there can sort of be a clinical predominant model, which is where you've got a clinical appointment, but you're interested in research. You've probably got some research training through a master's, maybe a PhD. And through your clinical role, you might be engaged in doing audits, reviews, quality improvement projects, supervising trainees on their projects. This is a previous version of the slide with a bit of, sorry about the lack of editing there. And, sometimes in that role, you might end up getting some funding from agencies such as colleges or, national bodies such as the Heart Foundation, Cancer Council, whatever. And this is obviously provides a really important opportunity to do research for many clinicians around Australia. Then I'd say that there's sort of this research predominant model, which is where alongside your clinical appointment, you've got an academic appointment at a university or like myself at a medical research institution where you source your own salary through grant applications, fellowship applications such as through NHMRC or MRFF. In my case as well, DFAT has been a bit of a funder for the offshore research that I've been involved in. And this can then open the door to larger scale research programs such as investigator-initiated clinical trials, such as Jonathan was describing in his talk. So I think, either of these pathways require formal training in research methods. These days in particular, there is a big focus on having a PhD, but people can still sort of come at these clinician researcher roles from a variety of different angles. And sometimes get a PhD along the way, not get one at all. But as you'll see later in my talk, for myself, I felt that I needed to do a PhD in order to gain the methodological know-how that I needed to do the sort of work that I was interested in. Why are rural remote clinical scientists needed in particular, given that the focus of this talk is on the rural remote workforce? Well, it's really because research questions need to be grounded in what are the genuine health service needs or the clinical management questions that affect the different places that we live and work. This is particularly evident in places like Townsville or Darwin, where we've got quite different disease epidemiology, especially infectious diseases, and when we have a very different, unique population. So you need research in these settings that is geared towards and provides the evidence base for this, the unique settings that we're in. And this leads to the generation of place-based, locally relevant knowledge. In terms of the personal benefits, and again, Jonathan covered this to a certain extent, I think having high variety in across my different roles is great in terms of maintaining workplace enthusiasm. I feel that I'm really fortunate that one day I can be in the radiology department chatting to the radiologist about the findings on an MRI scan of somebody's brain, and then the next day I might be travelling out to a remote community to set up a new participatory action research project. And that level of variety, I think, is just it's a great gift to have the chance to engage in that. I think, and again, this has also been covered, differing roles reduce burnout, given that, you know, it's not that research is easier than clinical practice or vice versa, it's just that the demands are quite different. So in clinical practice, you've got after hours on call, long face-to-face hours, lack of capacity to do work remotely or from home. With research, you might be able to have some sort of flexibility in your work hours, but there's this relentlessness of grant writing, the struggle for funding, the challenges of negative research findings, barriers to putting research into practice, the major challenges that you face in research approvals and so forth. So if you were doing one or the other full time, I think it would, you know, get somewhat draining. So therefore having a balance across quite different jobs, I think is very beneficial. And certainly in Darwin, we see that people that have a research portfolio can often end up staying longer. So it helps workplace retention, which is obviously so critical in our context. Just a little bit about how rural remote settings are different. So you can certainly go to national meetings where people will say, oh, these issues are just the same for us in urban contexts, there's no difference. You generally find those sort of comments coming from people who are urban based. So I think it is of high value to have that opportunity to work more remotely, to understand that the type of problems and the scale of problems are quite significantly different. There's no doubt that patient complexity is much higher, that the under-resourcing, which does face healthcare across Australia, is much more marked. And even just as one very small example of that, so one of the clinics that I run is a bronchiectasis, non-tuberculous mycobacterial lung infection clinic. Those patients all need chest physiotherapy. We don't have any chest physiotherapist in the top end of the NT. That's just, you know, one very small example. So there's a very high opportunity to make an impact because of this sort of under-resourcing. Obviously, the exposure to First Nations health is high if this is what you're interested in. I think there's this requirement to retain broad interests and skills the more sort of regional remote you work. So for a couple of weeks a year, I'm employed as a general physician at the hospital, even though I'm not actually trained as a general physician. But that is sort of the model of practice that Royal Darwin has. And similarly in my research roles, so sometimes, you know, I might supervise a cardiologist in rheumatic heart disease, a paediatrician doing a randomized controlled trial of rotavirus vaccines, a journalist who's doing her PhD in cross-cultural communication. So that there's that requirement to stay broad because there's just a few people here. So those people are all seeking supervisors. So someone has to provide the supervision. There was a question asked previously about funding opportunities. Definitely in a place like the NT, our local government funding opportunities and philanthropic wealth in the NT is definitely much less than elsewhere. But having said that, yes, there may well be some priority funding opportunities, such as when MRFF, or actually currently in HMRC, direct funding to you know, regional areas 2 to 7, which Darwin falls into, then you know, we can apply for those targeted schemes. And just further opportunities and challenges. So because there's fewer people to do the work, that provides high opportunity, but also excessive work burden. So that's both an opportunity and a challenge. There's a high pressure to focus on service delivery, not research. So that way of thinking is one that I often do try to challenge, to illustrate that research isn't a luxury item that you add on top once you've got a good functioning service. It's integral to improving efficiency and quality of your service delivery. I think one of the great things about working in a smaller town is that local networking is arguably easier. The same stakeholders that you're sort of interacting with through your research are the same people that you might see at the school drop-off and whatever, at the markets on the weekend. And I think there's a real, that human element, I think, is a real value of working and living in a smaller place. And I think it really does attract great people, so really committed, inspiring colleagues. I tend to find that I gain a lot of inspiration from the amazing people that I get to work with here. A challenge, though, is that definitely national and international networking is restricted, and there is a degree of social and professional isolation. If I get invited to a half-day meeting in Canberra, that's a minimum 3 days travel, especially because flights in and out of Darwin are so inconvenient and at terrible times of the day. So especially because if you're living remotely, generally you don't have any family around. If you're a single parent, well, you just can't travel. So definitely that's been an issue that's impacted me for the last 10 years. So I'm just going to focus a little bit on my personal career journey as well, since we were asked to do that. It feels a little bit indulgent, but it's sort of been nice to have the opportunity to reflect a bit on this. So I'm like David from Tasmania. I did my internship back in Tasmania, which I was told, oh, you'll never find a foothold back, you know, on the mainland again. Of course, you're going to get told that sort of thing by people that aren't, you know, don't have, you know, aren't open-minded about these things. So anyway, I started my medical degree in Tasmania and then sort of interrupted it with a neurophysiology honours year at ANU. And then for social reasons, sort of just decided to transfer my degree to University of New South Wales. And that really gave me an opportunity. This was in the early 1990s, and I happened to be doing my student placements at St Vincent's in Darlinghurst, Sydney, at the height of the HIV epidemic. And I was located on the HIV ward for a time, just when people were starting to get access to antiretroviral therapy. So this was a really fascinating moment in history and very much inspired me in infectious diseases. When I did graduate from that degree, one of the first placements that I put up my hand to do was to go to Alice Springs. I'd done a lot of reading about Aboriginal history, culture, politics, so I sort of felt like I was going into it with open eyes. And I found the experience there to be really devastating and soul-destroying in terms of the quality of care that we were providing to Aboriginal people, and the fact that the Western medicine that was on offer was just so deeply inappropriate and wasn't helping anyone. So I quit clinical medicine and decided that I couldn't work in such a system, and went and did a Master of Public Health at Sydney Uni for a year, which was a really fun, great experience and did re-inspire me eventually back into clinical medicine. And so I decided, yes, I would get on with physician training and infectious disease training. So to get into that and to be prepared to go and work in a place like Darwin, I did a diploma of tropical medicine and hygiene in the London School, and then finished my training at Royal Darwin that you can see there with its amazing new mural up the side of the building. And then, because I felt this strong commitment to going back to Alice, I did go back to Alice as my first year as a consultant. And in that year, recognised that actually, even though I had an MPH and I had a bit of biostats and epi skills and the DTM&H, actually I did need a PhD as well, because the sort of research that I wanted to be doing, I didn't feel equipped to do. I didn't really know how to use a statistical software program adequately. I didn't really know how to do multiple regression. You know, I needed those tools to be able to do any of the research that I felt was necessary. So I sort of took a bit of a sidestep and did my PhD on tuberculosis in the Papua province of Indonesia. There's a few stars dotted around on the map there, just indicating that along the way I've done some work in Dili and also in Malaysian Borneo. But anyway, for the last 14 years, actually, since finishing my PhD, I've been based at Menzies School of Health Research. So that's sort of the geographic journey, and then the sort of career pathway journey to sort of talk through alongside that. So just to summarise, I guess, as you know, I started as a doctoral student and then a postdoc, a fellow, a senior fellow, a division lead, and now deputy director. And some of the sorts of activities that you get involved in along the way include things like peer review activities, student supervision, being a co-investigator, getting involved in editorial roles and a chief investigator, and then often getting much more involved in research and institutional strategy development. So there was already a question asked about balancing roles, and one question is, well, how much clinical versus research? So I think if you're one of those individuals in the sort of research predominant model, then to me, I think the answer is simple. You need to be at least 60% research. And that's because if you're going to be a self-funded researcher getting fellowship and grant funds, then you need to dedicate quite a substantial amount of your time to that. And I think really the minimum is around about 60%. So if we're talking about balancing roles, then obviously the thing that always comes up is, how do you actually, if you're that busy across your academic work and your clinical work, how on earth do you, maintain a decent work-life balance? And this was just one paper that I found that comes up with 10 top tips. I don't have time to go through them, but I think it's always worth sort of having a look at these sort of things and, just trying to make it work and acknowledging that it's difficult for everyone. So in the next 3 slides, and then I'm pretty much done, I just did want to focus actually on my own research. And I've just picked out 3 things just to try to sort of describe the journey a little bit. This first one is relating to some tuberculosis research that actually this was when I was doing my doctorate. And it's an example, I suppose, of an unexpected output. When you go into a PhD, you say, this is my study protocol, this is what I'm going to come up with. I'm going to have papers 1, 2, and 3 as my outputs. But then, of course, all these unexpected things happen along the way. So one of the main unexpected things for me was that there's a T missing off the end of chest there, was that I found that there was no scoring system in existence for scoring the severity of pulmonary tuberculosis. So that involved a lot of sort of looking through very old papers and textbooks, but no such score existed, and I needed a numerical score as an outcome measure for a clinical trial. So I created one from using a derivation data set of about 200 X-rays that I read and a validation data set, and was able to come up with a numerical scoring system. And this was quite well taken up internationally because there were quite a few other researchers recognising that such a tool was going to be valuable for them. So there's been quite good uptake internationally and application across other infectious diseases as well, such as aspergillosis. So that was an interesting study to do. This is a study that I'm actually still currently involved in, which I'm really excited to be a part of. So as you probably know, for those of you who are clinicians working remotely at all, rheumatic fever is a key problem in remote parts of Australia, leading to rheumatic heart disease. And one of the big challenges is that there is no diagnostic test for rheumatic fever. So we did the START study, and that paper that you can see there, it was the protocol paper for that, with the intention of recruiting participants with rheumatic fever diagnosed on clinical grounds and various categories of controls to look at an omics sort of biomarker profile, looking at proteomics, metabolomics, and also antibody responses in great detail, more than had ever been done before, to really work out, is there a biomarker signature that can differentiate rheumatic fever from other diagnoses. And the analysis is underway, and there are some really promising signals coming out. That's then led into this new international network called the ARC network, recruiting participants from multiple countries internationally to see if such a biomarker signature can apply internationally and then be turned into a diagnostic test that can be operationalised for clinical use. And obviously then the big challenge is to make it affordable. So this is an exciting piece of work underway. And then a third program of work that I lead is the Communicate Study Partnership, which again sort of arose sort of serendipitously in a way, or just really in direct response to my observations of working in clinical practice in Darwin. So what's quite obvious is that there's racism in healthcare and that we're often very poor at providing culturally safe care. So one of my PhD students, Vicky Kerrigan, who had a background as a journalist, created this podcast in which doctors pitched their questions about how to work with Aboriginal patients to Aboriginal elders, the specialists who then answered their questions in this 7-episode podcast. Well, that's what she managed to turn all these qualitative interviews into. And on the basis of that, we've created a training program to try to train healthcare providers in providing more culturally safe care. One aspect of providing more culturally safe care is to improve access to interpreters for Aboriginal patients who speak languages other than English as their first language. And we've managed to succeed in getting interpreters employed and utilised and increasing the utilisation of interpreters over time. That plot shows over time from the year 2020 up to 2024. And the dotted green line is total interpreter uptake, which has sort of gone up compared to before. And that featured in the health report a little while ago, which was great. So this is my last slide other than my acknowledgement slide. So I think, I've described the geographical journey and the experiential journey, and then really the personal learning journey is that it definitely working in First Nations health, it is about lifelong learning and being an effective ally and being able to work out a way to not just go through those stages of grieving and disappointment about how awful it is, the fact that you have young people who've got end-stage kidney disease on dialysis in their 20s, or who have, really advanced conditions that ought not to be the case. So being able to come through that with optimism and to recognise that there's ways of being an effective ally and being effective in this context. Just to sort of get more personal as well, I suppose there's been a few crossroads for me career-wise. I think definitely I had to have a major career restructure around having a child. I couldn't do work in global health anymore because I couldn't travel. So that's why I started working more onshore in rheumatic fever and in the Communicate Study Partnership. I think I had to personally go through quite a big mindset change in taking on leadership roles such as divisional leadership, and now in the role that I'm in at Menzies as the Deputy Director for Research, because I had never felt that I was, that I wanted to do that. So that's been an interesting journey for me. I think one of the important mindset changes that I had was when I turned 50 a few years ago. I think because the culture of the researcher as an individualistic sort of highly competitive person had never sat very comfortably with me. I guess it was great, thinking, right, I've only got 15 more years that I have to, do this for. So really focusing on the succession planning and recognising that you can actually start focusing a lot more on mentoring and handing over the reins to others. I think I've enjoyed that process. In terms of where next, I think there is one big study that I want to do yet, which is a randomised controlled trial of treatments for rheumatic fever based on the findings of the immunological markers that we're getting out of the ARC network and the START study. So if there's anyone online who wants to, join as a PhD student or a postdoc doing a treatment trials for rheumatic fever, let me know. And continuing my role as a clinician researcher, I think is I just find it a very satisfying journey. So I'll be continuing to do that. I've been fortunate to have funding from a bunch of different agencies, and I've had a lot of very strong and helpful mentors over the years, and I also learn an awful lot from my PhD students and postdocs, and I'm grateful to a lot of them. There's too many really to be able to mention them all. Thank you very much.
Thank you very much, Anna. That was a fascinating journey and some amazing research you're doing. Interestingly, your call out for a student fits well with my first question, which is, what qualities impress you or do you value in a good student researcher?
Okay, great. Well, I think because those of us that work in this space are so time poor, the best thing is somebody who's very self-motivated and can get on and do stuff without needing a lot of hand-holding. I think that's difficult to say because there's probably lots of people who can get through a PhD if they have a lot of supervision. But the trouble is you really just don't have time to provide to you know, at the moment, for instance, with my PhD students, I meet them approximately fortnightly. I try to be as available as possible in terms of providing a lot of, you know, email and phone advice. But for someone to really fly in doing this sort of thing, self-motivation and just the ability to follow advice and follow you know, if you read their proposal and you say, look, I'm going to suggest changing this, this, and this, that doesn't flow, change your aims, this is what I suggest, being able to take that advice on board is, you know, that's what you need. And obviously in this sort of context, working in Darwin, having a high degree of cultural sensitivity and being very open-minded to recognising that there's, you know, that the dominant culture has a certain way of going about things, but that's not the only way, and being really open to learning. And I think Jonathan also mentioned the, you know, being able to critically reflect. They're all good qualities that you need.
Thank you. Another question. I've heard that managing demands of academia is difficult for women. How have you managed balancing research, clinical work, and family, especially when young?
Yeah, look, I think so the challenge for me was that I did what quite a few women in Darwin choose to do, which is to have a child of my own. So I was a single parent, and I don't have any family at all in Darwin. My family are all in Tasmania. So that poses a challenge, but the solutions to that are that you've developed really great networks of friends, and you find out that you make sure your child's happy to go to babysitters a lot. So I think you do have to get very organised. You have to drop a lot from your life, that, you know, things like going to yoga or whatever just go out the window. So I think you have to recognise that for a period of your life, you're not going to be able to do those things that you would love to do, but those will come back sometime later, and that's okay. And for me, they are now coming back because my child's now nearly 11. So, you know, things change over time. So yeah, it's just about relying on creating good networks, relying on those, being really organised, dropping what's not essential, but recognising it's only temporary.
That fits in with another question which asks, could you put the details of the article 10 top tops for work-life balance? I might ask if Leila could email that out to everyone who's enrolled with the session today. Another question, you mentioned a mindset change when taking on the leadership role at Menzies. What changed for you exactly?
Well, I think it was just a personality thing for me that I'd always talked myself into this role of saying that I'm not a leader. I'm a second-born child with a really bossy older sister. I played the violin, and I've often played the role of second fiddle, like quite literally, in a string quartet or whatever it might be. And I've sort of been quite comfortable with that position of not being the lead person, but the second person. And that's what I think I've talked myself into, you know, right up into my 40s. And so it was really having to recognise that even though I might have a fairly introverted, quiet approach to things, that there's still great value that people can bring to a leadership role, even if you're not the flashy extrovert. So, I mean, I think a lot of people these days, I think there's a lot more talk about leadership now. There's a lot more courses that you can do on leadership. I didn't really have access to those sort of things as I was sort of working through the system. So I think there's probably a lot more knowledge now about the fact that actually that you need a whole diversity of people in leadership roles. You don't just need, you know, the loud extroverts in those positions. So it was really just getting my head around the fact that, yes, I could do it.
Fantastic, and clearly showing your leadership with your presentation today. Thank you very much. We might move on, but I'm sure anyone who has other questions will be able to send them through. I'll move on to our next panel discussion once I master sharing my slides. And I'd like to introduce our four panelists. Joining us today, we have Dr. Sally Havers, who is an experienced infection control professional with a passion for safe patient care. She has extensive experience and postgraduate qualifications in healthcare management and policy implementation, and an in-depth understanding of the current challenges for clinical practice. She has coordinated multidisciplinary projects in infection control and infectious disease research, both nationally and internationally. Also, we have Dr. Rochelle Hine, who is an early career researcher and senior lecturer at Monash Rural Health. She has over 20 years industry experience as a social work clinician and manager in mental health, women's health promotion, education, foster care, and public health. Her research focuses on mental health and anti-racist practice, utilising participatory approaches to collaborate with populations marginalised in public discourse. Also, Dr. Angela Titmuss is a paediatric endocrinologist at Royal Darwin Hospital, providing outreach and clinical support for paediatric endocrinology across the Northern Territory. She is also Senior Research Fellow at the Menzies School of Health Research, and her research focuses on epidemiology, phenotypes and models of care for youth-onset type 2 diabetes. She is also exploring the growth, metabolic and developmental trajectories of children who are exposed to hyperglycemia in pregnancy, within the pregnancy and neonatal diabetes outcomes in remote Australia study. Finally, Professor Angus Turner is a founder and director of Lions Outback Vision. He's also director of the University of Western Australia's Centre for Ophthalmology and Visual Science, so that actually makes Angus my boss, and clinical lecturer for the Rural Clinical School at UWA and Notre Dame University. He was specific interest in providing high-quality health services to WA's remote and Indigenous communities, and actively involved in the delivery of specialist outreach services in WA's Kimberley, Pilbara, Goldfields, Midwest, and Great Southern regions. Thank you all very much for joining us, and we will now open the panel. I have a series of questions, but we will start with each of the speakers. Can you each tell us a little bit about yourself and your clinical and research journey so far? Who would like to lead? I'll do in order of introduction. Sally.
I'll go for it. Well, first of all, thank you so much for inviting me to be on the panel today. So I'm a nurse by trade. I'm a conjoint nurse researcher. I'm based in Toowoomba in Queensland, and I also am an infection control nurse or clinical nurse consultant looking after the infection prevention and control service that cares for all of our people in Darling Downs Health, which is a very large health service in Queensland. So we've got rural areas and remote areas and First Nations health as well. I have a conjoint appointment with Queensland Health and also with University of Queensland School of Nursing, Midwifery and Social Work. And I only actually moved to a regional area 2 years ago. So prior to that, I did complete my master's when I was in Melbourne, and I completed my PhD in Brisbane. So 2 years ago, I moved to a regional area. Interestingly enough, I had worked in research prior to or in between finishing my master's and starting my PhD in Brisbane. And I'd moved to Toowoomba to work as a clinician post-COVID. So obviously working in infection control, I was quite busy during COVID. And I'd been working at Darling Downs Health purely clinically for just over 8 months when I was lucky enough to get a role as a clinician researcher with a conjoint appointment. And so for me, it was really having the support of Queensland Health and my boss at University of Queensland, who encouraged me to take on a role and undertake research while still being in that area. So I'm very aware, as someone who's worked in urban areas, to then coming in to try and do clinical research or be a clinical researcher in a regional area. I'm very, very aware of the contrasts and the challenges. And I had a bit of a giggle before when someone talked about people saying that their challenges are the same, because I probably was that person 3 years ago. And now that I've worked regionally, I could laugh at that one. So yes, I primarily work in infection control and infectious diseases, but I have a real interest in implementation science and policy implementation particularly.
Thank you very much, Sally. Rochelle?
Yeah, hi everyone. So social work is my background, and I think my interest in research started really from my undergrad degree. There was a lot of emphasis on community development, research and evaluation in my social work course, and that kind of sort of cultivated an interest for me right from that early stage. I have always lived and worked rurally, so I used to be in southwest Victoria, and now I'm in the east in Gippsland. And all of my social work practice had a bit of a research and evaluation sort of blends to it. I was in service development jobs or health promotion jobs where I was looking at needing to be on top of the evidence and writing policies and developing evidence-based practice and creating change. And so, yeah, the previous speaker has talked about challenges of family as well. I'm a mother of 4 children, so I have just my 13-year-old with me now. The others are all adults. I'm about to become a grandmother too. So that's sort of woven in, I guess, with my research and my clinician experience as well to be quite a busy life. And I think you really need to have a passion and drive for research to do it, to sort of prioritise that in life. But certainly for me, it's my curiosity has fueled that, as well as my, I think since childhood, I've had a real drive for justice, social justice and equity. And I think that's a theme through the research that I do now. So when I was working in women's health promotion, I undertook a master's by research. So looking at mental health of older women in relation to sexualised media images and the impact on their body image and their mental health. And then my PhD, when I did that, I was working back in mental health again, and research and evaluation was a really important part of the role that I did. So it was a service development role around families where parents have mental health challenges. So from anyone who's in Victoria, you might have heard of the FAHMS program. And yeah, I kind of just fell into research there. So being able to engage with the research projects that were being driven at the statewide level led me to then undertaking a PhD in that area as well, around mothers with mental health challenges and recovery, looking at identity and connectedness. And I suppose then that has fueled the sort of research that I've been interested in since that time, looking particularly at the perinatal period as a time of enormous change and transformation for people, when families are really highly motivated to make significant changes in their lives to change generational patterns and adversity. So some of the research that I'm involved in now at Monash University, a couple of projects I'll mention. So one is on that theme of family mental health. So a project on stigma, so the experience of stigma for families where parents have mental health challenges. And we've collaborated with an organisation called Satellite Foundation, who are a specialist mental health organisation who provide programs and connections for children and young people. And also connecting with 18 rural young people in Gippsland who all have parent mental health challenges or substance use issues. And we collaborated with them in a couple of workshops to co-create a series of short films. And we've used those films to develop an advocacy and education workshop, which is going to be a workforce intervention to address and reveal and hopefully challenge stigma which occurs in healthcare settings. But the young people said it happens, it's quite ubiquitous actually, and it happens across various environments that they encounter in their daily life. So that's been a really exciting project because it's really generated new knowledge around the experience of stigma and the experience of epistemic injustice and the multiple ways that young people's accounts of their own lives are dismissed and marginalised and minimalised. So really excited to be in the translation phase of that research project. And another project that I lead with colleagues at Monash Uni is around the natural disaster experience. So perinatal women with mental health challenges during disasters. And I suppose, once again, the equity kind of lens on the ways that disaster recovery and response omits or ignores particular populations. And so looking at developing, co-designing a framework, an inclusive planning framework for looking at all the different stages of disaster planning, response and recovery. So I guess, yeah, now I'm actually not in a clinical role. For the last 4 years, I've just been an academic. And this discussion has kind of whet my appetite to, yeah, I'd like to probably go back and do some more practice. But I am employed part-time at Point 8, and I guess I cultivate that kind of interpersonal sort of change and work in multiple volunteer roles in my community as well. Yeah, so that's me.
Thank you very much. Angela.
Yeah, hi, I'm based in Darwin and I'm a paediatric endocrinologist and a general paediatrician. I grew up in Sydney, but I spent a lot of my uni degree doing placements in the Northern Territory, and I think that's really made me start to understand but also become really interested in Indigenous health. And so went to Alice Springs, back to Alice Springs as an intern and resident, and then came back as a paediatric registrar, and then kind of went back to Sydney to finish off or do the rest of my PEDS training, and realised I kind of fell into paediatric endocrinology in a little way, but through the paediatric training needed to be involved in research. I had some great mentors in Sydney that were involved in research, but it wasn't quite really the topics that I was interested in. I knew I wanted to go back to the Territory. And I was lucky enough through a colleague in Sydney to be introduced to Louise Maple-Brown, who actually became my PhD supervisor and big mentor to me. And the Pandora project that she was leading, very much, she was looking for a paediatrician or someone to be involved in that. It fitted exactly with me being dual trained because I was looking at both the endocrinology aspects as well as developmental aspects for the kids. And so it really was this project that fitted exactly what I was interested in. It was a project across the whole of the Territory, so included lots of visits to remote communities and met a lot of my passions. And then as a clinician researcher, I'm the only paediatric endocrinologist in the Northern Territory, and I realised very quickly that what can change kind of practice or change policy is both data and also the voices of people affected directly by the health condition or by the issue. And my research now involves both data in terms of epidemiology, but also the voices or lived experiences of young people and communities, and how that often is very powerful in changing how health professionals act and models of care, but also changing policy or practice. It's quite hard to ignore a voice that is sharing their lived experience. And so I really enjoy that aspect of working in the Northern Territory. A lot of what Anna had said really resonated because I could see the pros and the cons and the challenges that she talked about very clearly. But it's a real privilege, I think, to be working regionally, and also as an early career researcher. I think you have opportunities to progress further into research than I would have if I had remained in Sydney. I definitely feel that I've been given many opportunities and had amazing mentors that may not have been the case if I had stayed in a tertiary centre.
Thanks, Angela. Angus.
Thank you, David. And it's a pleasure to be here today. I've crossed paths with David many times for some unknown reason. I went to Launceston when I was at primary school as a new immigrant to Australia from South Africa. But then I ended up in West Australia. Then I ended up back in Launceston training as a registrar for a time. And David taught me how to do some surgery in the Launceston General Hospital. And then I ended up back in Perth because my actual passion all along has been the rural practice, and I was a keen student advocate for rural health. But I also was really passionate about ophthalmology. While I was training in Melbourne, a professor there, Hugh Taylor, he wouldn't get off my back in terms of doing some bits of research while I was actually trying to be a busy registrar and pass exams. So I found I was a bit of a reluctant engagement with research initially, but by the end of my training in Melbourne, I needed to finish all sorts of loose ends. So I joined him as a sort of research fellow and focused on workforce and service delivery. And part of that journey has then continued, and I've ended up the last 5 years being based in the Kimberley, which has been an absolute privilege and pleasure to be a specialist in the outback. And the reason for all the research, in a sense, has been the drive to provide the evidence and make sure in your advocacy efforts that you've got a base of material to help decision making. And then, like many of the speakers have said, there's been so many opportunities to have quite a broad research focus, because at the pointy end of rural practice, everything seems to be relevant. All the latest technological advances or a whole wide spectrum of conditions, everything's really at the coalface quite challenging. So my latest research is actually engaged with AI. And it's amazing how, even being in the remote middle of nowhere, according to the World Platform, with the technology, we've been able to have global partnerships with Google, with Aravind Eye Hospital in India, and really bring together some of the opportunities to use for our population's benefit for service delivery. So it's a really amazing life to be a sort of busy clinician scientist in the bush. I really feel it has an even more rewarding edge than my colleagues that I see in the city, where clinician scientists just seem to battle traffic jams. I think there's something to do with the balance of, yes, family and community is hard to always fit in, but when the commute's short and the community you bump into as your patients and as your colleagues, I think you can really make all the things meld together. So I appreciate that at the moment. Thank you.
Thank you, Angus, and some really interesting and slightly different experiences. So one of the questions I have is, looking back at your research journey, is there anything you would do differently? If so, what? Would any one of you like to put up an answer for that? No regrets.
I think the serendipitous nature, David, of what we do is we've all told stories about how we were in the right place, right time, but that's just kind of keeping an open mind to opportunity as well. And I think trying to carve out your dead set plan is going to be bound in quite a bit of disappointment. So I think being open to what's available has helped, and maybe that's why less of us have regrets.
I think I would have gone sooner. I would have moved to the regional areas sooner, David. I think there's an idea that you have to follow a certain path, and maybe the open-mindedness part is part of it as well, Angus, is that you won't have those opportunities, or that it won't be as easy. And I wish I think I wish I'd moved earlier. I think we'd talked about it as a family for quite a while before we actually committed to doing it. And it's interesting that I moved, and then a few months later or 6 months later, the opportunity presented itself. So opportunities will present themselves if you're willing to, I guess, be open-minded and go looking. And I wish I'd moved earlier. I wish I'd made the move and been brave to move away from that metro, approach, because the opportunities are there if you go looking. So that's my biggest regret, is that I took so long to jump.
My biggest regret would be, but as a sole practitioner of my particular specialty in a very large area, it is really hard to balance both roles, and trying to advocate for the need for an additional person and kind of like balancing the sustainability earlier and trying to really push for that very early in my move. Like, I've been up in Darwin now 7 years, but it's that kind of workload is immense, and that would be my regret, would just be how to balance that and advocate to people that can act earlier with that. Yeah.
Right, thank you. How important is it for you to have a mentor, and how did you find yours, or mentors?
I think having a mentor is a significant resource in any field in life, really, not just in academia, but certainly, the academic world is very different from healthcare. And so to orientate you to all of those different systems and expectations, it can be very important. I think having a mentor who, being very, very clear on and goal orientated about what you want to gain out of the mentoring relationship is good. And different mentors will be appropriate and relevant and important at different parts of your life and different times during your career. But yeah, I think the opportunities to kind of open doors, to gain a different perspective on how things are and how things, what opportunities are there for you. Mentoring is really important.
Can I make a comment, David, as a nurse? I think one of the things that's really obvious, even hearing everyone talk today, is that research, and particularly publishing or postgraduate, isn't necessarily something that nursing mentors might always encourage. And I think the biggest thing for me as a researcher was having mentors or nursing mentors especially, who said, give it a go. What's the worst thing that's going to happen? You can have a go, and really encouraged me to publish, to do research, to actually do some of those quality improvement activities, but to think of them in a different way and to be willing to put myself out there a bit. I think, there is a tendency perhaps in nursing not to go down that path. And I think I was very lucky from my perspective to have mentors, nursing mentors, and some now still, who really push me out of that comfort zone, because it is a bit trickier in nursing. It's not just expected that you will publish or will do research. So I think as a nurse, having mentors that are willing to push that is a really big part of me going down that path.
Right. Any other comments?
I'd just say, David, I think a mentor that's willing to challenge you as well, that is willing to push you or make you think of a different perspective, is really important. You don't want someone that's going to give you the answers you want all the time, but someone that is going to make you think differently, and someone that thinks strategically as well, or that is kind of like a selfless mentor, kind of that they want to help and support you and think of opportunities, rather than it's not about them. They're really about mentoring that next generation or that next group of people. And to have a mentor like that is a very special thing. But I think it's really important, because those kind of opportunities provide, those serendipitous opportunities provide pathways forwards that you wouldn't otherwise have. Yeah.
It's helped me think, actually, because when we have med students that we are mentoring, I tend to try and be super encouraging and just friendly. But actually, when I think about it, who's been my mentors, they've been the ones that have prodded and poked me to do things differently, as mentioned there. And in fact, David Mackey, when you started in West Australia and you prodded and poked to make me do things that were uncomfortable, that was helpful. So yeah, I think I'm going to take that away and stop being too friendly to the med students and give a bit of a nudge. Thanks.
Challenge everyone. So another question I have is, how do you manage the demands of a clinical career with the demands of research? I remember asking the same question of how much research, how much clinical, and the answer I was given was, 60% research and 60% clinical. So how do you all balance it?
I think it's an ongoing challenge. For me, my research is very much enmeshed with my clinical work. Like, it really influences my clinical work every day. But it's very much an ongoing challenge. And I think I had this very false idea post PhD that you just had this thing of getting through your PhD and you thought that things would somehow be easier on the other side. And I've realized, actually, no, that is not at all true over the last few years. And it's the constant challenges of grant writing and realizing that people's livelihoods or their jobs depend on you getting those grants and things like that, keeping your team and keeping projects sustainable and things like that. And I find that it's an ongoing challenge that I don't really have the answers to, but am constantly trying to navigate.
Okay.
Finding long-term people to in the team, growing in people's strengths and not trying to do it all oneself, has taken me quite a long time to understand. And when family come along and other work balance things are required, potentially then you start to rely on your team a lot more. And I think not trying to be at everything and trying to the video conference has been a brilliant thing for us in the remote areas, but it's also made it hard to say no. And so you end up having too many meetings, actually, whereas in the past you could just weren't there. So I'm just trying to still navigate that space, but trusting and not having the ego to be everywhere at once.
Yeah, and I think there is, in academia, there's a really toxic culture of overworking. Long hours, and that it's almost like a badge of honor to be really, really busy. And I think it's incumbent on all of us to kind of push back against that a little bit as well, and make quite realistic timelines when we're applying for grants, and just that every task you do is going to take at least twice as long as you anticipate. So making sure that things are a little bit more realistic. It's difficult in amongst the competitive nature of grants, because you risk someone undercutting you with that sort of stuff. But I'm kind of quite mindful now of taking care of myself and my team as well. And we're all health researchers, so we should be taking responsibility for being role models in that as well, I think. And ultimately that leads to more meaningful and better quality research, rather than trying to cut corners and get papers published really quickly. Yes, something I've been thinking about in the last couple of years.
Good point.
Okay, next question. What do you think's the hardest part of working in a rural or regional setting?
I can say for me, it's resource and just building any type of research capacity. So we might get some funding to do some things, and there's just no one really to do it. A lot of our regional sites are extremely short-staffed, so adding anything to their burden is just not fair. So it's really difficult. And I think too, having building researcher capacity is really hard. For me anyway, within my team, I have a number of people who report to me, and have really tried to build some capacity and capability and do some, small projects with them to try and boost their ability or, knowledge and experience. And it's just extremely hard to build that capacity within my team and within the hospitals as well. So, I do get a bit jealous of some of the other bigger sites in the city who have research assistants and research nurses and research coordinators and all these wonderful people doing all these wonderful things. And I'd just love a research nurse for a few hours a week to help with a few things. But where there's a will, there's a way. And I do know that there's a lot of interest and engagement. So it's really just sometimes finding those people who are willing to do it on the side, which you don't always feel great about asking, that sort of thing, but you can see that it's going to make a big difference. So for purely logistically for me, when I'm talking about the challenge for us, it's resource. It's really hard to have that resource to keep things moving and to get things going from a research perspective.
Other challenges?
I'd agree with the resources, but I also think that can sometimes be a pro in terms of like the smaller number of people involved means you actually, in a regional or rural place, most the people, you build up those kind of networks both professionally and personally. And sometimes you have a greater voice to translate your research than you would if you were in a city. So you actually have a voice to government or to others that you wouldn't otherwise have. And so you can actually have a greater impact possibly.
Yeah, that's very true. I've got a project that we're starting at the moment, and the pool of people who'll be doing the work is so small, and they know every single person, every single potential participant. They will know very well all the way through. So loss to follow up will be reduced because everybody knows exactly who's involved and what's happening. So you're right, it's a definite pro from that perspective. But when you've got that level of engagement, it's just hard sometimes to get there first.
And I think Anna mentioned this in her lovely talk about the kind of travel time for a short meeting in the city. You actually just can't be at the table, so you still have to get involved by video, and then you kind of miss out on that networking that we all know is really helpful for thinking time and ideas for the future. So it's a bit more lonely on the networking side, but you're also asked to be at a lot of things because you represent the voice for rural issues, and that's great that we have that kind of podium, but it is a little bit of a disadvantage from the country.
Yeah, I was going to say similar, just that lack of visibility, I think, in the field or in the broader environment when you're kind of a little bit isolated and invisible in your rural location.
Okay, so looking to, sorry.
Oh, no, sorry, I just agreed with what Angus said, that as a clinician researcher in a rural remote area, you often end up some ways more visible than your colleague because you end up on every committee you're like supposed to represent, but it's actually not sustainable, but it is an interesting way that works. So you kind of, your voice is heard, but if you did that all the time, you'd never get any work done. Yeah.
Okay. So a more positive thing, what's the best part of your current career? Could everyone give me a quick answer to that?
I'd say the variety. Yeah.
Yeah,
I just feel like I can make a big difference to the people that like in my community. I feel like I can see how such small things can make such a big difference to people who, from an equity perspective, are already disadvantaged in some ways. And I just feel like I can make a big difference in research in this space.
Yeah, I agree with Sally, especially having having that clinical lens as well. You can have that knowledge and expertise about what is going to make the difference and what the core problems are. And then with all of those relationships that you have, those close collaborative relationships with all the different stakeholders, you can sort of develop an intervention and evaluate it quite effectively and efficiently. Yeah.
Yeah, I mean, lastly there for me would be that translational element is key, because as a clinician scientist, we're very close to what we're trying to actually implement. And in the rural area, it's even closer because the feedback loop is your friends and patients. So I think I really appreciate that in the country.
Yeah, I appreciate that feedback loop really well. And the variety every day is very different. You can be like in an office one day, on a small plane, doing outreach the next day. It means it also keeps the research very real and very embedded in real life. Yeah.
Fantastic. Okay, how do you manage personal, family, and other commitments alongside your career? One of the questions I have is, if you have children, what happens as they get older and, you're able to have them educated in the town that you're in, or is that a challenge?
My children are young, like they're not at school yet, so I don't have really, but I don't think it'll be an issue in Darwin. But it is an ongoing issue, and also balancing that. I know that every day they ask me, or like, where are you working today? And like they got quite used to the fact that I'm going on a plane today. And I'll be back for dinner or something, and then like that, oh, you're in the big building today, and you're like, oh, you're in the small building tomorrow. Like they quite see that as just the normal reality. And even like the 5-year-old is asked me quite a lot of questions about what I do and what the young people that I look after do. So she's just kind of accepted that that's a normal aspect of life to balance those. And I suppose also seen the reality of some late nights. I know I was trying to finish my PhD. I was on maternity leave with my second child, and there were some very late nights trying to get it in, and they have just grown up expecting that is kind of the norm, that the flexibility is good, but it also means that they also see it kind of coming, like the flexibility of research to be able to be around is excellent, but it also means it's also done at home as well. Yeah.
I've got kids the same age, 3 little ones that have only just entering school age. So I'm not at that front, but I mean, where I live in Broome, there are good high schools, and I think you can make it work, and it's just choices along the way. But at least our town has a high school option. So
my kids are at school, but we've got good schooling options here in Toowoomba, so that's good. I actually find it much more manageable in living in Toowoomba than I did living in Melbourne or Brisbane, for example, where I used to have to commute for nearly an hour and a bit every day each way. So if I get a call from the school, I can be at the school in 7 minutes, not an hour and 7 minutes, which is really good. So I find that I'm actually much more available to my children than I was before that. And I actually think it's really great for them. I was the same. I did my PhD, had my second child while I was doing my PhD. They've seen me do lots of late nights, but it's part of the job, and I think they see that as they're proud of that and proud of the work that I do. And as a community-based person, a nurse that works at the hospital, that's something that they are proud of as well. So I think being a clinician researcher and being very visible in the community is actually something that they are probably really proud of. So there's that as well.
Yeah. My children are aged between 28 and 13, So they've kind of grown up with that similar experience that everyone's talking about, and lots of late nights and things like that. I think with now, just with my 13-year-old, it's a very flexible and maybe a non-routine sort of life. Sometimes last night I was on a Zoom meeting at 9 p.m. This morning I just didn't start work till a bit later. So it's the flexibility, like other people have said, is really great for being able to participate in children's lives. There are some, heartbreaking moments when you miss out on things. But all of my kids have a really strong work ethic as well, the adults, and I think that's sort of come through. And now that they are past the teenage years, they can express that they're proud of me as well, which my youngest is not quite at that stage yet, but. Yeah, I think family life just has to work around work and vice versa as well.
Great. One of the questions I've had come through, and I'd like all of you to comment on this, is it important to work with a major metropolitan university, or have you worked with the regional universities as well, or only them? What's your advice with that?
Well, and so I'm quite lucky. We have a well-established research institution in Darwin, like Menzies School of Health Research, and so and through that we have collaborations with centres across Australia, and also in my area with in the US and Canada. So I feel like we're well connected and have those connections, and I think there's benefits of both. Like I think the local institution has that rich context, and that but it's also important for me clinically as well to really maintain those clinical networks with interstate, international colleagues, particularly as my research area is a very rapidly changing area and kind of really changed in the last 10 years. And so there's not huge numbers of people across the world working in that area, and so those kind of connections are important. And I have to say, I don't feel like it's ever been seen negatively being somewhere from a regional area in any of those kind of collaborations.
I think the size of the university or its location is kind of irrelevant. Like for whatever research project you're doing, you need to be partnering with the people that have the expertise, whether it's lived experience expertise, academic expertise, or clinical expertise, that you're going to go to wherever they are. And, these days I'm involved in a few international projects, so it's not just, based in Australia, and the others are the same. So, yeah, location seems to be a bit irrelevant, I think.
Yeah, I agree with that.
We're lucky in Toowoomba, we actually have what's called the Southern Queensland Research Hub, SQRH, which is based at one of the hospital campuses. And I'm very lucky that I get to sit there and talk to other people. So, and that's a mixture of universities have spots there. So we get to collaborate. And again, I don't think it matters so much, because it's around that collaboration and that those relationships that you establish with other researchers, other clinician researchers. It's a very multidisciplinary area. We've got pharmacists and doctors, all sorts of different academics there, and so it's a really good opportunity. So I would say that it's definitely not a requirement. It's around really finding the research group that you want to work with and the collaborators that you wherever they happen to be, and those relationships that you build with those people, I think.
I have another question that's come in relating to that. How do you suggest an early career nurse gets started in research? I have found opportunities are limited in a rural setting compared with urban settings.
I feel like I might be a good person to answer that one. So I understand why you feel like that. I think the biggest thing is to find your area that you're interested in. A lot of people today on the panel and also our speakers have talked about having that real drive and interest in what you want to research. And I think if you are interested in going down that pathway, then really link in and try and find key people within your structure, whatever that happens to be. If, you know, most of the states would have either a network group that you could link in with, or similar people like myself who are doing research within those areas or in the regional areas. They might not be in your specific area or field, but you can reach out to them. Most people would be more than willing to have a chat. Really look at what postgrad work you want to do. So unless we've already finished your postgrad. But yeah, I think it's really about finding people that you can work with and finding opportunities and finding support, and then finding some funding is the other big one. So you know, I know in our health service, our foundation offers grant money, and it's not a lot, but it's a little bit, and those types of things are really the beginnings of being able to do some more work. But I'd always be happy to take questions from people about it specific to them as well.
Sally? Okay. One last question then that's come in from the audience. How do you change workplace culture to foster an environment conducive to clinical research in the rural, remote setting?
I'd say like in Darwin, it's actually almost just what happens. So many clinicians in the hospital work also at Menzies and have a research career, varying percentages or varying degrees. And it's probably not the experience necessarily everywhere, regionally or rurally, but I feel very lucky to be in an environment like that where it is just a culture that happens, and therefore it's always being used to improve translation and being used to improve models of care practice. And there are a lot of mentors and people that you can see balancing. And so when you see that happening, then that's an expectation that you do as well. And so I think you have to see it to actually want it. Yeah.
Okay, well, thank you very much to our panel. Sorry, I've been given the wind up. So it's fantastic hearing everyone's stories, so inspirational, and you know, I'm sure that people will be in touch with you if they have specific questions. You're also generous giving your time today, but also for your whole research and clinical dedication. I'd like to finish now acknowledging the people who have supported the Life as a Clinician-Scientist program. Getting my slide sharing right again. The many organisations. I hope this has been inspirational. We would welcome feedback from everyone. You can complete our online survey if you link with the QR code here. And if you have any suggestions for us, that would be great. Thank you again once for being here today from all around the country. I'd love to hear what are all the lands everyone is from today? Could you send us that information? It'd be nice to build up places that we don't usually hear of apart from, in the major city local peoples, but we've got a lot of other Australian Aboriginal communities that often don't get heard about. And I'd like to thank Leila very much for all her organisation with the team at the Academy and our truly inspirational speakers, and reminding everyone again that this will be on the YouTube channel for the Academy if you'd like to go through any of the talks again. Thank you and have a great afternoon, everyone.